Yes.
All right, well, I'll go ahead and kick us off. Hi, everyone. I'm Shannon Roberts. I'm a program manager with the Peer Recovery Center of Excellence. I'm joined today by my colleague, Mari Nichols, who helps lead our efforts on workforce development. And I'm also joined today by Julie Early and Wendy White-Tygreen. Julie was our lead author, researcher, and basically data guru, doing a oh, thank you, Julie, for sharing slides. Helping put together a report on Medicaid reimbursement for peer support services.
I do need to look at this. It's Medicaid reimbursement for peer support systems.
Just a quick reminder as you join, please mute yourselves.
There we go.
Presentation go a little bit smoother. Anyway, so this presentation is all about the report that we published in May. I'll make sure to throw that link in the chat. We have Julie here, prime author, to kind of present the findings that we had. Going over the report, we'll have time for Q&A at the end of each section. And then we also have Wendy White-Tygreen here to help kind of answer those broader scope questions. And she's an expert with on Medicaid reimbursement for peer recovery support services. So with that, I'll just remind folks, this is our disclaimer statement that we are SAMHSA funded. So things expressed written in materials are not necessarily direct reflections of endorsement by the US government. A few other housekeeping notes, like I said, myself and Maureen will be in the chat. We'll answer questions as we're available to. There are also, once Julie's wrapped up with her section, we'll have some time for questions. And then we'll also have some time after Wendy's portion for questions. After this presentation, probably tomorrow afternoon, you'll get an email from me with the recording, the slides, a link to the report, and then also a link to an evaluation. We're SAMHSA funded, and so we like folks to give us their feedback that informs future presentations. All right, and I think with that, I will hand it over to Julie.
Haha, I had to hit that marker on the bingo card. I had to be on mute for this presentation. It's a requirement, right? I'm Julie Early. I work for the Texas Institute for Excellence in Mental Health, or TIEMH. We're a research institute in the Steve Hicks School of Social Work at the University of Texas at Austin. And I work with a great group of folks. So TIEMH has a broad range of projects, but our little area of projects that we focus on is evaluating peer support services in Texas. So my colleague, Dr. Amy Lodge, for instance, looks at peer workforce outcomes. I have another colleague, Raven Garuda, and Dr. Stacy Stevens-Manser. They are working on looking at the utilization of the peer support services Medicaid code here in Texas at the local mental health authorities. I have another colleague, Dr. Pallavi Singh. I got to give everyone a shout out. These are awesome people. Who's working on outcome measures with this consumer operated service providers in the state. And I got the opportunity this year to provide support, and I'm evaluating a project where my colleague Jesse Davis and we contracted with Shireen Caraco to work with leaders of peer-run organizations in Texas to develop content to support the capacity development of peer-run organizations in Texas. That was the Peer Organization Growth Academy. It was a one-time project. It's done. But then Peer Recovery Center of Excellence invited me and Dr. Amy Lodge to work on this project to do an overview of peer support service certification, training, and Medicaid reimbursement structures and rates across the nation. We're very excited to be invited to do this because my direct supervisor, Dr. Stacy Manser, had done this kind of as a labor of love. PRCE was able to take it on and adopt it and grow it to this point where we're able to do a presentation like this with the SAMHSA funding. So I'm honored to be here. I hope this information is useful, and just thank y'all for being here. Thank you for your time. So the agenda today, we're going to go over first how we found the data, and then the findings themselves, and then the premises behind what feeds into all of the Medicaid funding, et cetera. And that's going to be Wendy taking on that. And then we're going to provide, and she's also going to do some reflections around that information. And then we're going to go over some special notes, limitations, recommendations, y'all's questions, and then we'll wrap up, and everyone will have a beautiful day after this, I'm sure. So real quick, all the data was compiled from states documents as of October 2023. And if you, I'm going to say this now and I'll say it again in a minute. If you see anything that for whatever reason, you're from a state and we present information and you're like, hey, I have better information than that, here is the email address, and I bet Shannon's going to drop it in the chat as well, where you can send that. Alrighty, so finding the data. So the process used was a desk review, and what that means is I sat down in front of my computer and I attempted a Google search, and then ultimately ended up going to the websites for the various states' health departments, health and human services websites, whatever states might have those labeled as. And we looked at Medicaid provider manuals, Medicaid billing manuals, fee schedules, and just any other document that might have information about the peer support services in those states. We did 4 sweeps of the data. So we started in December 2022. We did another sweep in July of 2023, another one in October of 2023, and then finally a final one here in March of 2024. The Center for Financing Reform and Innovation came out with their financing peer recovery support report, and we found that there were differences between their data.
That does make sense.
Very transparently, every time we did a sweep, we found either updates, either the states had changed their data, or I found where I had not perhaps dug deep enough. There was additional data or corrections that needed to be made. And so what I want to honor is that there are challenges to finding data this way, right? You have a human being doing a search with a concept that is not exactly Googleable. The algorithms don't search for this very often. And also the states every state organizes their information differently and in a diverse way. And that contributes to, and also information is nested, and, you know, there might be a rock I didn't overturn. It really was an excavation of data. And so we want to honor the fact that the information in this report is working information. This is a working report. Again, I'm going to restate what I said earlier. If you are in a state and you see information that is not accurate according to what you know, please send that to PRCOE and we will update the report. This report represents progress in that it brings all this information together and we're able to share it. And it also maybe sets forward a process where this information can be improved. Alrighty. So what did this process identify? So we found which states offer reimbursement and kind of the structure of that reimbursement. So one-on-one reimbursement, reimbursement for group peer support services, reimbursement for mental health and or substance use peer support services, or both. We found the reimbursement rates. We also looked and tried to find the Medicaid funding authorities that states use. And also billing codes that the state use. So the peer support services billing code under the Centers for Medicare and Medicaid Services is the H0038 code. However, there were some states that utilize different codes as well, and I'll show y'all that here in a little while. And we also looked at the modifiers. So those are these alphanumeric codes that are added to the billing code that kind of specify services. And that specification could usually indicates where peer support services may be provided, or to what kind of group of folks. So we wanted to bring that information onto the table as well. Something I want to note is that the report, as far as like the intricacies of funding funding authorities and Medicaid goes, there's a section of the report that is actually kind of a primer on all of that. And all of the resources that we used to present this information, the websites and the documents on the websites are listed and linked in the back of the long report, as well as all the rates that we found, all the billing codes, all the modifiers. Those are
Let
in
me
the
make sure I'm on mute. Hold on seconds.
Oh. So what this process did not identify. So in this process, there are many instances where states allow peer support specialists to build under different Medicaid service or program codes. For instance, psychosocial rehabilitation or some community behavioral health service, that kind of thing. We didn't look at all of that information because, quite frankly, that would be a whole other report. We also did not have access to anything that told us about the utilization of the peer support services billing code. Now the fun part. So we're first going to present a summary of the findings around one-on-one peer support services. So a quick note, states that offer reimbursement, and y'all may know this, but I'm kind of I like to state the obvious. States that reimburse for peer support services under Medicaid have to meet certain requirements put forth by the Centers for Medicare and Medicaid Services, right? They have to have a structure for supervision, training and credentialing, and then care coordination built into the peer support service and preparing peer support specialists for providing the service. This was first set forth back in 2007 with the original Medicaid letter that said, hey, you can now bill for peer support services. There's been an update recently, and the one thing that stands out in that update to me, as someone who works in this area, is that it has been specified that peer support specialists, so in the original letter, it said that a qualified mental health professional could be the supervisor, right? Now they've come out with an update that says, yes, that can also be peer support specialists who have met the criteria to be supervisors under the state's program. So I just wanted to note that. That's exciting news. So going into the specific findings. So 48 states offer reimbursement for one-on-one peer support services. We found that none of the territories, we were not able to find any evidence that the territories currently, so America Samoa, Guam, Northern Marianas Islands, Puerto Rico, or Virgin Islands, and South Dakota do not currently meet the CMS requirements. And then two other states, Vermont and Wisconsin, they offer training and credentialing, but they do not reimburse for peer support services under Medicaid. We have, I'm not sure about Vermont, but we have verification from Wisconsin that peer support specialists can bill for, say, again, psychosocial rehabilitation, but they do not currently utilize the peer support services code. In this information, we were able to find 45 states with known reimbursement rates. So in the documents for Florida and Tennessee, and if there's someone here from Florida or Tennessee who has this information, please send it. We were not able to find the rates in the available documents. For Michigan, what I was able to discern, and if, again, same thing, if you're someone from Michigan, let us know the skinny. It looks like Michigan pays a flat rate, or the term might be capitated rate, to the certified community behavioral health clinics. And so peer support specialists, or peer support services rather, are part of a service array offered in these clinics, and a flat rate is paid, and people, I guess, are able to select from the service array. That's a structure that I'm kind of curious about. I need to do more research around that. All right. So as we reviewed the rates, first, I want to emphasize that all rates presented are adjusted to the 15-minute increments. That's usually how the documents showed them. There was one exception, and a little bit later in the group peer support services, the California rates were they were at first showing the full one-on-one peer support service rate, but I had to go into the manual to find that, there's actually a calculation for figuring out the group 15-minute increment. So I'm saying that because if you, for instance, go to the California rate and look at their rate tables, you'll see the group peer support rate, and you'll see that it looks like the one-on-one peer support rate. But if you go to the manual, there's additional information. All right, so what we found is that in the structuring of the rates, there were states that combined reimbursement for substance use and mental health peer support services. Now, what we mean by that is that states reimburse for both, and they do not distinguish by billing code or billing code modifier. So there are 19 states that combine reimbursement for one-on-one peer support services. The rates ranged from $7.83 to $23.09. And there are 3 states that have multiple rates. That are Arkansas, Arizona, and Wyoming. And Arkansas, their rates varied based on whether support was provided via telephone and or in person. And then for Arizona and Wyoming, there were different rates for managed care organizations administering the peer support services, and the state plan paying for the peer support services. And I'll be honest, right now, I can't remember which rate is which, but that, again, that is in the appendices and indicated in there. Okay, so we found too that there were states that separated reimbursement for one-on-one mental health and peer support services. And what we mean by this is that states either used a different billing code or they added a billing code modifier to the H0038 code. Now, this table is a very busy table. I'm going to own that, but it really is busy because it reflects the complexity of how states do that have separate reimburse for mental health or substance use peer support services. There are 15 states that separate this reimbursement, and there are 8 that utilize the same rate or rates, and 2 of those states have multiple rates. And I'll go into the reasons why for multiple rates in another slide. There are 7 states that have different rates for mental health and substance use peer support services, though. And this is where it gets very complicated. 2 have multiple rates and different rates for both. 3 have multiple rates for mental health peer support, but a single rate for substance use peer support services. And then 2 have 1 rate for mental health peer support services and multiple rates for substance use peer support services. So we're going to look first at the states, the rates for mental health peer support services for these states that do separate reimbursement for one-on-one peer support services. So these rates ranged from $7.34 to $221.25. Now, that outlier there, that's California. California was very interesting because their rates varied by county, and it was kind of a mix of the ability of counties and payers to set rates. And again, there in that appendix, there is a full list of those rates by county. There are 7 states, including California, that have multiple rates for mental health peer support services. And in addition to California, there's Georgia. And Georgia, what we found was those varied by level of care and whether the support was provided in or outside of a clinic. Illinois varied by setting of service, so similar to in or out of a clinic. They had different settings. Minnesota varied by the level of certification for the peer support specialists. New York varied by upstate and downstate. Oklahoma was varying by whether it was delivered by telephone or in person, and Oregon was by setting. Now for the states that separate reimbursement for one-on-one peer support, we're going to go over the substance use peer support services rates. Those rates ranged from $7.34 to $110.37, and 7 states have multiple rates. Alabama, for instance, those rates varied by the population that was supported or the program. So youth peer support services and peer support services provided to folks who are pregnant, and also what they called what was labeled the state opioid response. There were rates that differed for those different areas. California, so here it's still by county and also funding authority. So I'm going to back up for a minute. The mental health peer support services in California and some of the substance use peer support services, if I'm recalling correctly, it's also an opioid response project under an 1115 waiver. Those are programs that the county opts into. The mental health peer support services are also a waiver program. And so that's where the variability is. However, for substance use peer support services, California does have a single statewide rate, and that is $20.38. Georgia varies again by level of care and whether in or out of a clinical setting. Georgia is one of those states that has the same rates for mental health and substance use peer support services. Missouri varied by telemedicine or in person, and again, New York by upstate or downstate. And adding layers to this, New York also varied by setting and program. And then Oklahoma, again, by telephone or in person. There were also some states that only offered reimbursement for mental health peer support services, and that's 6 states. And the rates for these states range from $10 to $31.50. The District of Columbia has multiple rates based on from what I was able to discern, a population receiving services. Now, something I want to note about this, of this list of states, all of them offer certification and training for mental health and substance use peer support services. But Hawaii is the one state that offers, I didn't say that right. All but Hawaii offers certification and training for both. I apologize. Hawaii is the only one that only offers certification and training for mental health peer support services. Now, for states that reimburse for only substance use one-on-one peer support services, there's 6 of those. The rates range from $15.07 to $24.94. All have a single rate. And of these states, all of them offer certification for both except New Hampshire. Now we're going to go into group peer support services. So there were fewer states that offered reimbursement for group peer support services. There were only 26 states. And of those, we were able to find reimbursement rates for only 23. Idaho, Oregon, and Utah, they in the documents, I was able to find that they offered reimbursement for group peer support services, but I could not find any rates. Now, for the states that, similar to the one-on-one peer support services, there were states that combined reimbursement for mental health and substance use group peer support services. There are 11 of those. The rates ranged from $1.26 to $9.32. Again, these rates are adjusted to 15-minute increments, and they are, I believe, per person in a group. I want to make a note about this. We found in the data, and we didn't report this, but this is something that would be interesting to look into deeper. Each state had kind of a variety in terms of the maximum number of people that could be in a group. I can't remember the range right now, but tell you what, if someone wants to send that question, I can look that up on a table and send that. But I think that should be something that's reported on eventually. There were 2 states that had multiple reimbursement rates. Again, that's Arizona and Wyoming, and those rates varied by whether it was the managed care organization or the state plan administering the payment. All right. Again, there were states that separated reimbursement for mental health and substance use peer support services. There were 7. 4 states utilized the same rate or rates for both. 1 state had multiple rates for group peer support services, and 3 states had different rates. 1 had multiple rates for both. 2 have 1 rate for mental health peer support services and multiple rates for substance use group peer support services. States that separate reimbursement for group peer support services, looking more closely now at the mental health peer support services, the rates ranged from $1.61 to $49.17. Again, California is where the higher rates were found. 2 states had multiple rates. California, again, varied by county, and Georgia by level of care and setting, similar to the one-on-one peer support services. States that separate reimbursement and looking at the substance use peer support services rates for group peer support, the rates range from $1.61 to $23.77. And there were 4 states that had multiple rates for substance use peer support services. Alabama, and those rates varied again by population, California by county and program, and Georgia by level of care. And then Rhode Island was interesting because what I found was that it looked like Rhode Island had different types of groups, but I wasn't able to really determine what the differences were, but there were 2 rates found in Rhode Island. It is possible that 1 rate is an older rate. I want to own that. If you are someone from Rhode Island and you have information about that, please send it in. All right.
Really quickly, that last slide, I think the header should have said group, right?
Yes, it should have. And that will be a correction that I make before we send it out to
No
folks.
worries.
Thank you, Maureen. Details. All right. Sorry about that, y'all. So for states that reimburse for only mental health group peer support services, there were 2. District of Columbia and Minnesota, the rates range from $6.45 to $9.54. District of Columbia, again, has multiple rates based on the population receiving services. Then lastly, as far as the rates information goes, looking at states that reimburse for only substance use peer support service, group peer support services, there were 3. And the rates range from $1.94 to $9.76. Now, we're going to go into a summary of the findings for the Medicaid funding authorities. Once again, the long report provides an overview of the funding authorities, including details of how states share the funding with the federal government, the differences between the various waiver programs. For time's sake, I'm not going to go into the details about all that, but I will describe what we found as far as which kind of how the different funding authorities and how the states combine funding authorities. Similar to the rates and billing information, finding the funding authorities took turning over more rocks. And so I'm pretty sure there are rocks I did not turn over with funding authorities again. It was not always explicit. There were some billing manuals that said this program is funded by this, and that was very easy to find. California, for instance, had that very explicitly in their billing manuals. For other states, it took more excavation. But what we did find was that there are 38 states that utilize the state plan, and that is administered either directly by the state and fee for service or through a contract with a managed care organization. 24 administer directly through the state plan, and 30 contract with managed care organizations. 19 states utilize the Medicaid waiver authorities, and that there were 7 that utilized the 1915 waiver authority and 13 that utilized the 1115 waiver authority. And again, the main report will go into more details around the differences of those funding authorities. All right. So looking at states that combine the state plan and the waiver authorities, there were 9 states that did this. And even in the midst of that, there were some states that utilize fee-for-service managed care organizations along with a waiver. For Alaska, I do want to note that I found that they did have a state plan administration, but I couldn't determine from the information I found whether it was through MCO or directly by the state. There were 10 states that utilized only the funding authorities. 4 utilized the 1915 waiver authority, and 6 utilized the 1115 waiver authority. And there were 29 that utilized the Medicaid state plan funding authority only. And so for some states for 17, they used both managed care organizations and administered directly through the state fee for service. 9 used managed care organizations only, and 3 administer only directly through the state. Now, we're going to give a summary of the findings, kind of specific to the billing codes and modifiers. So, whoops, there we go. So we found that, just for those of you, because this was an education for myself. So billing codes are used on the claim forms, right? And these are standardized through the Centers for Medicare and Medicaid Resources, and also generally utilized by private insurance as well. And it's a standardized coding system called the Healthcare Common Procedure Coding System, or HCPCS. Again, what we want to emphasize is this report focused on the peer support services billing codes, not peer support specialists able to bill under other billing codes. But we did find that not every state that has designated peer support services utilizes the H0038 code. 45 did, but there were 7 states that utilized other billing codes. So for instance, California and Maryland, they use another code to designate group peer support services. And then Illinois, Massachusetts, Oklahoma, and Virginia use other codes for their peer support services. Illinois is unique because they use a different code for substance use peer support services, but the H0038 code for mental health peer support services. For modifiers, so under that HCPCS system, 2 character alphanumerical codes can be added to the billing codes to add some specificity to a service provided. As noted earlier, some reimbursement rates vary on where a service is provided, how or to whom, and under what program peer support services are provided. This list of modifiers, now, what I want to emphasize, this list of modifiers, there were 39 states and there were 84 modifiers. And rather than present those as like a very long list, I went through and I kind of consolidated those under headings and these are headings that I created now. And I want to own that because there were some modifiers that may or may not have fit exclusively into one of these headings, but I put it in there anyway. The list of modifiers, though, is in the back of the report, and also in the back of the report, this though a same state might use the modifier as another state, states had different labels for the modifiers, and so it's interesting to read through how the states label those modifiers because it gives insight into what peer support services looks like for the individual states. And now, and I'm realizing I didn't pause so Wendy could introduce herself, but this is now Wendy's section of the report on the premises behind Medicaid.
Hi, everyone. It's great to see everybody, and just really glad to be here. The work that Julie and the team have done is expansive, and it really gives I think, a lot of opportunities for each of us in our different roles, right? Like I see folks on the screen, many of you work for managed care companies, many of you are direct practice peer specialists. Many of you are advocates, state authority representatives. It could be the Behavioral Authority and Medicaid Authority, but I recognize so many of your names. So I think each of us kind of has a different lens in looking at this data and information. And so we're really glad to be able to present this in short form today. Understanding, again, I hope everybody saw the link that is in the chat to be able to access this for a much deeper dive if you are that kind of policy geek. And we those of us who are policy geeks kind of hope you are. So I think that's also really a good opportunity for folks who want to get into that level of detail. So Julie, if you'll advance the slide. So Julie's provided, right, like all of this information about rates, but depending on who you are and what your background is, there is likely, a different opportunity, right, for you to kind of understand this. So you may not have any understanding, you may have deep understanding of this, and this won't even touch the surface of your depth of knowledge, but we wanted to just put some basic information out in front of you about how rates are set. And so there's some basic premises here, and then we're going to drill down and talk through some more of this about more detail and content about how rates are set. But basically, in fundamental Medicaid policy, what is understood is that the reimbursement rate, which is paid, should address that the cost of care for delivering the services are covered. And that includes a fair salary for the person delivering the service. And again, these are big Medicaid premises. So this means for a physician who may be treating you for the flu, this could be for a nurse who is administering a particular type of injectable medication. It could be for a physical therapist who is going to do a particular type of intervention to relieve a particular ache. And it definitely means a peer specialist who are providing a behavioral health intervention of peer support. So think about it really broad right here. That's the level that I'm approaching you guys at. So it should be about the fair salary for the practitioner. And then it is also inclusive of all the administrative cost and overhead for the service, and also benefits that would be expended by the billing organization for the practitioner. So if, for instance, in a hospital emergency department, when you're thinking about the whole cost of your emergency department staff to set that kind of rate, it includes the building there. It includes the supplies in the emergency department. It includes your staff leave. If you work with a staffing agency to staff up the emergency department, that in community mental health, if you think about like benefits, it would pay for like sick leave or paid time off. So those types of benefits to the practitioner. So it should be pretty comprehensive in what is included then in the building of a rate so that cost is covered, right? So these are fundamental premises, y'all, right? Like I know y'all could push back and go, but Wendy, I've had to struggle and walk that line every now and then as well. What I didn't say earlier is I'm actually with the state of Georgia, and I am the director of the Office of Medicaid Coordination for the state. So I do all things Medicaid for the Behavioral Health and IDD Authority. And the reason why I'm here today in this particular conversation is I was also the original negotiator and collaborative writer, policy development wonk who helped birth the first Medicaid peer support service in 1999. So I've been doing this for peer support work for a long time and doing Medicaid work for a long time. So together, this presentation really is some of my sweet spot interests. So again, you see that content about what rates should address. So then for outpatient services, there's a couple of different lenses through which rate setting is considered. So again, the cost reimbursement content at the top is always kind of gathered and analyzed. But in many cases, if it's a new service or it's a service that's never been done in like a particular geographic region, or it's a new service type by a practitioner, that you can look at other fee schedules. So you can look kind of at proxies. So the nice thing about this particular product as a tool in each of your hands is when rate setting is occurring through plans, and Medicaid is an insurance plan, then you can use the content that is in this report to say these things are quite similar around the country. And if you're under any of these average rates or the highest rates, you can use this kind of as a point for some advocacy that this represents other fee schedules. The other thing, other fee schedules can also be, for instance, if it's known that like a private plan is hiring peer specialists and they're hiring them at certain salaries, but a local provider is only receiving Medicaid and the rate's been low, you can think about if there's payment or reimbursement that is transparent, right? Sometimes these things aren't. But if you're a mental health center and you are being reimbursed by another payer at a different wage or different reimbursement rate, then you can use that when your state does a Medicaid cost study and share those types of fee schedules or consider those types of fee schedules. So next slide. So you heard me kind of weigh heavily in my language on the concept of those are the premises, because then the way it plays out in real life is variable. And so there are some real challenges and opportunities I might press when we think about the reimbursement rate for peer support services and how to shape that in the future. So I want to just, again, spend some time on each of these with you guys and kind of expound on each of these so that you are considering the best way of absorbing and contemplating these rates in your particular jurisdiction. So the first bullet, like all of these are just so critical. So I want to say this one's so important. This was the most important, but they're all very important, y'all. So I'm just going to hover on each one. So first bullet, although transparent, right? Medicaid is transparent. Rates are published, like Julie was talking about all the ways she found them. Medicaid state plans and waivers. Again, if you're a policy geek, they are all posted on federal CMS's website. It is equally as difficult as Julie was looking for all the ways to find the rates. In state product, it is challenging still to find those on the CMS website. Like unless you go in there and you practice touching that system all the time, that portal all the time. But those are transparent, so you can find them. Now you've got them all in one report for this point in time. But Medicaid authorities have to have state funding in order to leverage the Medicaid funding for reimbursement. So your state may very well know that your rates are out of date, but your legislature is not fully prepared to do a new appropriation to support the rates going up. So let's say, for instance, your rate is $10 for 15 minutes and you want to raise it 10%, right? So you want to raise it to $11. So that's $1 per unit. That money has to come from a state budget. So it doesn't have to be appropriated as new money. It could be redirected. The state can make a decision to try to reduce some cost on one thing in order to advance some utilization and cost of another. And those of you who tune into like peer support webinars on return on investment, it's a great conversation to have and understand outcomes. So like, let's say, for instance, you can save on the number of hospitalization, inpatient psychiatric hospitalizations with the use of peer support. You can have a conversation with a Medicaid agency about potentially advancing the rate or building more utilization on a particular service like peer support to offset and bring down some expenditures on another side. So, but there has to be some allocation of resource, generally through state appropriation if it's something new. So sometimes that means a rate study is done in a state, but is never implemented. So I know many of you have experienced that. Georgia has experienced that before. And it's an ouch. It just hurts. But it is a nature of the Medicaid business that there has to be money put up by the state for the Medicaid, for every Medicaid dollar. And that varies from state to state, but states have to put up match. So it has to be in a budget somewhere. So second bullet is Medicaid managed care. And Julie made a couple of references to this. So I'm going to bring it to life. A state like Tennessee that has managed care for its Medicaid products, the federal regulation out of Medicaid, this is not your state trying to hide anything, but the federal regulation is that managed care companies don't have to publish their rates. They could share that, but it's not always transparent. So I made the point in the first bullet that Medicaid rates are generally transparent unless it is under a managed care framework. And if it is under a managed care framework, then the managed care companies have the option of not publishing that rate. And so it's not out in the ether. So when Julie said, I can't find that, that is not because Julie wasn't diligent, because y'all can see the kind of detail work that was done by the whole team that Julie's presenting on the work for today. Sometimes that's just not public, and sometimes it's even variable. So again, if you're not familiar with managed care, you can broker just like Julie was talking about, there's differences in these rates across states or certain jurisdictions or for levels of care. The managed care company has the prerogative, in accordance with regulation, to even contract with ABC, super behavioral health provider, at $10 for 15 minutes. But EFG, behavioral health provider, they might contract with because they haggled and negotiated, and they're only going to get $8 for 15 minutes. So that kind of business model that managed care brings to Medicaid makes this type of research a little bit more challenging. So I think it's just important for all of you then to know that sometimes that managed care content is not as available. So if you're in a state that's primarily managed care, this one's a little bit tougher to kind of ferret out and discern. So then peer support practitioners, the whole field is 25 years old. It was 25 years old on July 1st, y'all. And I know because I sweat the whole way into getting it approved by federal Medicaid, July 1st, 1999. So that's not a long history for a practitioner type. And so what happened historically is, okay, well, Georgia got it approved, and we didn't get the rate we asked for originally, by the way. And we had to negotiate with CMS because there was no equivalent. There was no proxy. There was nothing like this that had ever been done. And so we ended up getting a really low rate to start with. It pained us, but we got it going. And subsequently, in the late 2000s, we went back to CMS, and there still weren't very many states to serve as, to establish what I would consider in Medicaid language, the market for something, right? So, I mean, we all kind of know about the range for computers, right? Like a standard average, desktop, you've got the low end, you got the medium end, you got a high ends, right? And we all kind of know that market now. But when I bought my first laptop in the early 1990s, like I found one and I was like, sure, this astronomical number now seems like it's really reasonable. Like there was no market. There was nothing to kind of drive down the price of laptops. There wasn't good comparison shopping in my hometown at the time for that, right? But like that's back when things were new, and then people start producing, and now there's a market. Same thing for these types of practitioners. So now we got a market, y'all. Julie's put some stuff out there. The market's still wildly variable, as you saw those ranges, but that is largely because as Georgia came into the Medicaid frame and we negotiated, got a really low rate, we kind of came back and said, oh no, that's too low. That is not a livable wage. And we went back to the table with CMS and we used alternate proxies in Georgia. Because when we looked at like a sample of about half a dozen, 6 to 8 other states who had done this by then, we then still didn't like the rate because everybody was just using Georgia as a comparable, and Georgia had to set it low because CMS was like, there's no market. So we ended up using other types of certified professionals to get our rate. And if you look at it, it's really on the high side, and we are about to raise our rates in Georgia. It's a range of between 25 and 39% for peer support. Again, depending, Julie was telling you, Georgia, we do it kind of differently. It's different if you have a bachelor's or high school level education. It's different if you're in clinic or out of clinic, one-on-one in group, right? So there's all those different factors that change that rate. But we can only together shape the market if we are all together working on the market value. And so that's why a presentation like today is so very important. So next slide. Okay, so this is just placeholder slides for reflection. So go ahead. Thank you. So changing landscape. Okay, so this is what's ahead, right? We're not stuck in this place. Having these types of conversations today make you all empowered to have impact, right? So this is just like Wendy being chief champion and chief cheerleader. I like to empower people to go make radical change. And so I just want to pause here for us to contemplate this landscape and for you to think about then the skills that you will have with this content today to have empowered and policy changing conversations. So first, think about that larger market now that I'm talking about. That becomes a larger wage sample. So, I mean, like I just told y'all, I'm super jazzed that Georgia's getting a giant, it's on average about a 34% increase per unit on the peer support services. I'm loving that. It will only drive the market a tiny bit, right? So even if Georgia leapfrogs, and I'm not sure it will because I looked at that California rate, I'm like, wow, look at that thing. Whatever that one jurisdiction was, I'm like, whoo, I love that. But if we continuously challenge the healthcare market to pay what peer support is worth, then is when we all kind of start turning the dial much more significantly. So for those of you who have a low reimbursement rate right now, just contemplating the content from today's webinar should begin to help you have more informed conversations. And money talks, y'all. Like I could talk all day long about the return on investment and the power of peer support. Where I drive things mostly is through policy and finance. And so even if you're not like a finance wonk today, you've learned a little bit more to speak it and speak this language. So the larger market though, and then reports like you have now here in your hands and we're presenting on today will drive that kind of change because you'll have data in hand. So don't always settle for the average. Don't always settle for like the top 10 or top 15 percentile. Be sure to just use all of the tools in your toolbox along with return on investment information to really push these conversations. Because the other thing that's ahead, when I talk about return on investment, value-based purchasing has been talked about for a while, but the Medicaid and Medicare systems have been a little slow to get masterful at implementing, but it will be coming. So keep your eyes on that as well. And any of the study and the research that's happening on the value of how peer support changes lives, enables folks to work, enables folks to have a meaningful relationship, enables folks to stay in community, to have family restoration. All of those things are going to be crucial in those future conversations. So the second thing, there is a lot of buzz and hum, and I think the deadline for giving feedback on this is this week, but there is for many years, peer support has not been a recognized guild. And when I use the word guild, I use it very intentionally. And I do so out of like a social work framework. I'm a social worker. And so the Guild of Social Workers, it's a professional classification. And if you say you're a social worker in Georgia, there's pretty much a generalized understanding that you could be kind of understood in terms of practice also in Alaska, two opposite sides of our country. And so there's power and collaborative identification and a cultural construct that comes with kind of being a guild together. So SAMS has been pushing this through the use of the model standards that have now been released by SAMHSA to talk about what is a peer specialist, but also what has emerged in about 2 years ago, maybe 3, is that there was a standard occupational classification that was released called Community Health Worker, CHW. And many of you know what CHWs are. And it's a really broad category. There's lived experience framework that's talked about a little bit with that, but not the way the behavioral health space talks about lived experience. And like in terms of like prerequisite and training on using that skill as a tool in enabling and lifting up recovery in others. But folks really, I think nationally are advocating for peer specialists to have its own classification. And in doing so, then nationally, things are counted. Things can be recognized, and then data is able to be gathered on the peer specialist in a way that's different from CHWs, but different, but equal to other types of guilds like nurses and social workers and professional counselors, psychologists. So just be attuned to that, because ultimately classification then allows more data to be collected on wages, which wages in a Medicaid rate are often kind of lost in the mix. It's a part of the reimbursement rate, but it's not the sole part of the reimbursement rate. And so therefore, we're not getting a lot of good national data on a regular basis about wages. And so I think that would be very important. And I'm trying to watch a little bit of the chat, but yes, the National Association of Peer Supporters, Dana Fogelsong, have been like leading a lot of the dialogue on this. So I wanted to bring that to bear here. The next thing on the changing landscape is Medicare recognition. So thanks, Dana. The comment ended yesterday. Okay, well, y'all can still create buzz and hum about it because we want the committees to be sure that they understand that there's some passion behind the conversation. So Medicare recognition. So folks may not kind of understand, but out of federal CMS is called the Centers for Medicare and Medicaid Services. So Medicare and Medicaid are like the largest insurance plans in the country. And Medicare generally covers folks who've been disabled for an extended period, and they cover the aging population. So Medicare has been known to create a standard often where private insurers will follow. So this is a really important recognition. So with Medicare's acknowledging that peer support is a recognized service, with that, there are what's called Medicare Advantage plans, which some folks who are aging can select an alternative to Medicare or a supplement to Medicare. And when they do so, all the things that are on Medicare are generally covered. So interestingly, this recognition in the Medicare framework should begin to create much more learning, much more advancement of funding peer support out of private plan payers. And when I talk about a private plan, talking about something like, Aetna or Blue Cross Blue Shield, Anthems, United, like all of these big insurance companies, big and small insurance companies who cover behavioral health. And so that will also start to come into the mix of rate setting because it's going to create other market drivers. So we have to have our eye on that. And then finally, now with Medicare recognizing peer support, and other Medicaid products recognizing this more, there's also this movement for primary care physicians or even pediatric practices. If you think about parent and youth peer support, there are primary care models that now recognize peer specialists as one of the team members. Federally qualified health centers, with called FQHCs in our acronym land. They are doing these team-based approaches that include peer specialists. And Julie was mentioning early CCBHCs. So CCBHCs, certified community behavioral health clinics, they actually have a bundled payment rate for a myriad of behavioral health supports. So a daily rate for including things like doc, nurse, individual counseling, but peer support is a mandatory service that has to be included in the package for reimbursement. So many states like Georgia, we will, those of us who are implementing this know peer support's a mandatory service, but it'll start to get lost maybe a little bit in the CCBHC reimbursement because it's going to look like an umbrella service, but it's going to be required as a subset. Now, most states are requiring sub-detail, like encounters to be submitted. So you might could see the H0038 that Julie was talking to you all about underneath that umbrella, but it's going to require a little extra digging in the future to find peer support there. It's not discriminatory against peer support. Nursing will be harder to find. Psychological treatment will be harder to find. Like it's all bundled then under a new header. And it's a great approach to community behavioral health, but it may give us a little less data for analyses such as these as we begin to move forward. So next slide. Okay. So opportunities. So I think just to kind of wrap our big dialogue points and to spend some time then fielding some questions. So all of us have an opportunity to influence the emerging and future rate structures. And so like how do we shape the analysis? So I advise that using this kind of data that's included in this report is a great first step. The second thing that I think is really important is to use wage equivalence if you hit a wall, right? Like I think content like this today is great, but again, if you are a low, if you're like in the bottom third of reimbursement rates in the country, and you have a dialogue with like an actuary who works in a Medicaid system to do rate setting, and they're like, well, let's just use the national average. That doesn't get you very far. It doesn't get you to the front of the pack, right? So it might be an easy solution to get to like using midpoints for rates and reimbursement across the country, but it doesn't supercharge your jurisdiction then. So I think using this kind of content, but if you're still going to be kind of low or midpoint and you do want to do the supercharging, think about whether within your state do potentially certified addiction counselors, do they get paid more in your state? Or do other certified health techs get a higher wage in your state, even if it's not in the behavioral health lane, right? Like if there's a certified tech who does some work in physical therapy, or if you think about, for instance, like a tech who works in developmental disability services, and that's a higher wage. Consider these wage equivalents for the type of work they provide and see if you can kind of take that oh, I've got all this data now from Julie and the team at the Peer Recovery Center of Excellence, but I want to supercharge it. Think about that wage equivalent content and data that you might can look for. And then again, market data. The second bullet, and again, like I know I'm talking like an economist a little bit. I'm so sorry if that's not your lane. So I'm trying to talk about it simply, but most Medicaid studies are done looking at what is the current cost within the state. Well, if you hired on a rate where you're being reimbursed just like $5 for a 15-minute unit, then you, as an agency, have not been earning a lot of money to pay the peer specialist a decent wage. So you have been suppressing the market and suppressing the wage because all you're getting reimbursed is this little piddly amount. The piddly amount then is going to be used in the cost formula to say, well, how much does this cost right now? And it's going to create the cycle of continuing to suppress the rate that emerges. So you're going to be stuck forever with, a wage of potentially a fast food worker, which is not acceptable, not acceptable to anybody who would be on this call, and not acceptable, really, I would wager, to most folks in the world. So we're not going to stand for that. We're going to think about then market data. So even if you don't get the supercharge that you want from a wage equivalent in the bullet before, think about bringing to the table where peer specialists are being advertised in your region, for instance, like if there's a job offering from, let's say you're a public agency, but you go pull the wages for a job description that's coming out of the VA. Or maybe there's a RCO, a recovery community organization in your area that's not billing Medicaid at all, but their peers are making $10,000 more a year out of some grant funds. Bring those wages to the table. So think about using market data outside of a Medicaid system to bring to anybody who might be studying this. And then, of course, you've heard me now dribble a little bit about value-based premises. So there are emerging pilots and emerging studies, as well as there are some actual Medicaid mechanisms. And you heard Julie mention something like called the Medicaid waiver. Some of the Medicaid waivers have some value-based purchasing aspects to them. And again, those are going to be heavily anchored in outcomes. If we do this intervention, we're going to get these better outcomes as we're going to save money. Well, some of that savings needs to be reinvested, right? Either for more utilization or higher wages or better reimbursement, but it can increase the value. So keep that in mind. And then also continue to contemplate this team modeling that I mentioned. So in primary care practice, pediatric care practice, in the FQHC model, there is this team-based approach now to collaborative care. And there are some codes, they're not peer support codes. You'll never see them as H0038, and they'll never be billed, and you'll never be able to discern that in a research study like Julie's done right here. But those are generally triad teams where a physician has to be kind of at the top of the triad model, but it can include what's called a behavioral health tech. And it can include like a licensed practitioner in partnership with that physician to do some really great wraparound support for someone out of a primary care doc's office or out of a pediatrician's office within the FQHC model. And that behavioral health tech can be a peer specialist. And so we have the chance really to inform and shape these new emerging models and have them really recovery informed by having that behavioral health tech be a peer specialist and showing the benefit and outcome there. Okay, next slide. Which is, so go ahead, let's go ahead and advance one more. Which is back to you, Julie. I think just closing the session with the limitations of the data, and then we will field some of the questions that have been shared in the chat.
Yeah, I mean, you know, I really appreciate presenting with Wendy, because it's like, okay, here's a little data, and then Wendy's like, here's how you use it. Here's how you're going to take this and turn it into something you can advocate with. But again, with this data, and we want to honor the fact that there are limitations to it. The data collection process is a limitation. And also the data do represent a point in time presentation of the current rates. What we noticed, like I said, in those 4 sweeps, there were rate changes. And this was something, in hindsight, I wish I would have tracked which states and how many states made rate changes and at what dates. Some recommendations are, I think the biggest recommendation I would have is this is information that would benefit from validation directly with Medicaid contacts in the state. Build and somehow collecting that information about who to contact. And also, as going through this process, there was something I was noticing, and the modifiers kind of hint at this. And I think this goes to, some of the, getting peer support specialists established in the SOC. But there were various ways that states describe peer support services. And I think it would be beneficial to look at those various ways, because there is a fidelity to the role. And it would be important for an establishment of kind of, this is what peer support specialists do, for there to ensure fidelity to the role. And now don't take that for me to imply that I saw lack of fidelity, but there was just a very big variety in the description of peer support services. And I think it'd be interesting to see what that looks like. Also, utilization of the peer support services billing code by the states. As I mentioned at the top of it, I have colleagues that are looking at this in Texas. In the POGA project, I was talking to someone who is a proponent. If you happen to know folks who may have connection to that or may be willing to assist with that process, that might be something to explore as well. And at this point, it is question time.
So, Julie, while you were just wrapping that up, I started going through. I answered several questions while you were presenting, but I'm going to spotlight a couple of things for us to address here quickly. Tanya Cooley, I just wanted to hone in on first on your question. That she's saying, for those who aren't looking at the chat, that sometimes there's a disconnect in the rate that gets reimbursed to a behavioral health center for Medicaid, and then what the wage ends up being. And you can't look at a rate and say that should all be my wage, right? Because sometimes you look at it, you're like, wow, if I do a group and it's 10 people and I get to bill this, and all of a sudden there's like dollar signs all in front of you, and it's like $250, $300 an hour. Sweet. Remember what goes into the rate has to pay for the EHR and copy paper and supervision and travel, insurance to cover cars that are going to be traveled in. Like it includes all that. Still, I will share that in Georgia, the last time we had the opportunity to change rates was 2008. And that just pains me. That just pains me. But the wage that rate was built on, folks are still making that wage in Georgia 15 years later. And that's not cool. So what I do in my state seat is I share the wage publicly every chance I get with providers and with peer specialists and with advocacy organizations so that folks have the chance to self-advocate. Now, folks roll their eyes a bit at me in state government when I do that, but state government does not really dictate salary ranges except for those with whom it hires or with whom it contracts. When you do Medicaid rate setting, that's very removed then from the Medicaid agency. And so I just like to publish that. So I will tell you that for a bachelor's degree in Georgia, coming up with the new rates, we use the wage of $55,000. And that's for bachelors. And so I just did a presentation Tuesday afternoon on this. So I will continue to talk about that so that folks have a chance to advocate. And will an agency be able to afford that? I don't know. I'm not managing a managing CEO for all these companies, but I will give a peer specialist a decent sense of what they can use as an advocacy point. Because doctors have a chance to do this. They know what the wage is in their state. They have an association that does that for them. Until we have more strength in the guild and guild association support and advocacy, then I think those who are just recovery champions have to lean in a little bit that way. So if any of you are in state roles, I might have just hurt your feelings, but I suggest putting that out publicly. If you get queries, blame me, I'll take it. That's how we're going to advance the field. Okay, and then I saw another question about resources for peer specialists in working in CCBHCs. I will tell you that the state TA center for CCBHC implementation emanates from SAMHSA to the National Council and provider agencies. They just changed their name from a National Council for Community Behavioral Health. Has changed over to Resiliency and Wellness. I think y'all. I keep reversing the orders of their new acronym. My apologies to any NatCon folks who are on today. My apologies. They're working on some content on this, but certainly I think there's a little bit of product out there and more emerging soon. I'm looking at the fact that we've only got 4 minutes, y'all. I'm just trying to look at the remainder of the questions. RCOs, let me just say, the Center of Excellence for Peer Recovery has some product and webinars that have been done just this year on Medicaid billing for the Recovery Community Organization. So I would encourage you to reach back into that website. And if you can't find something, Chris Kelly can be a resource on that. Julie, I'm scanning too to see if there's anything that's in the data sweet spot. I see y'all are debating in the chat like the different names. SAMHSA has kind of emerged in the past 2 years with the phrase peer support worker, which is really generalist. So I think we all have to kind of navigate the fact that we all have different naming conventions.
I think the only data question I saw was from John Marston. And John was wondering about the list of the 24 states that MCOs negotiate rates with, but it looks like Shannon provided the link to the report. If John's still on, let us know if that answered your question or not. And then there was one person offering a correction for South Carolina's certification and training. And I'm not finding that one. It's lost in the shuffle, or my brain cannot find it in the list of chat responses, I should say.
Sure. So a couple of other questions in that I'm gonna take in the last 2 minutes. I'm gonna give each 30 seconds. Are any states doing peer support for people diagnosed with chronic illness? Many states right now are using the whole health action management curriculum and doing for folks who have behavioral health conditions plus a chronic condition. Georgia bills that under peer support whole health. So it's a different code. It's not H0038, but it's a peer support centered delivery model for creating whole health support for an individual. And then the second question that I just am going to quickly tackle, Molly Brown, is mileage covered? That is a state-centered approach, but if an agency considers mileage in its cost report, then that is included in the rate setting. But most states have policy on billing for travel time or not. Most states roll it in. So they lower the productivity rate, knowing that you have to travel out of a clinic. That's why Georgia has an out-of-clinic modifier, because we pay more when we do out-of-clinic time. So you don't bill travel, but you get a higher reimbursement rate because you can't see as many people back to back. So it is very state-centered on how that plays itself out, Molly. So I can't give a single generalist answer. Your local Medicaid agency should be able to tell you. So with that, Shannon, Julie, et al., we are at 2:30.
We are. Thank you so much, Wendy and Julie. And just so everyone knows, I have saved the chat. So anything we didn't get to, I'll make sure to share with Wendy and Julie. We'll gather some resources and answers and get that back out to everyone who attended. I'll also include slides, the recording, other resources and links that were shared in the chat, and an evaluation link about this session. So thank you everyone for being here.
Shannon, there is one raised hand, and they've had their hand raised for a while.
That's okay. I can lower it.
Okay, I'm sorry.
I had one of the questions in the chat. I work for a large medical institution, so I'm in a different place. Like I don't work for, we've never done this. We don't bill. I'm the only person that's a peer specialist. So I was just wondering, like, how do we document, or how do I document? So that could be a further discussion, or somebody can email me, because I have many people here at the university that want to start to do this. And if we can do it, let's do it.
Yeah, I invite anyone who has requests, like on behalf of their organization, or even if they're just the only person at their organization. I know a few folks DM me. Go on to the Peer Recovery Center of Excellence website. I know I linked it earlier in the chat. I'll be sure to link it in the email too. You can request technical assistance from us, and that you can be an individual or an organization can do that. And we can assist you in setting those things up.
So they would like even help set up or teach as far as like the billing part of it goes with my RCO team and my revenue cycle team. Oh, wonderful. Thank you. I have a huge smile on my face, even though you can't see it.
Good to hear.
I scream at the top of my lungs to every single doctor, every provider, every student, everybody that there is, that there's peers, and you don't need to shut down in an appointment with a patient. Just come and get me and I'll talk to them as a peer. And then it's opened up a huge world for patients to keep coming back and get the healthcare that they need and they deserve.
Awesome, thank you. All right, Anna, you, and then I'm gonna wrap us up.
Okay, thank you. Just a quick question, because Wendy, you raised the idea of the guild. One of the challenges that we're having is this conversation is happening throughout the country in pockets and then nationally with some other people, and getting all the conversations together and pulling in the same direction is a challenge. Do you have any, are there any models or frameworks on how to get this done that we could bypass the reinventing the wheel piece of trying to get organized?
I don't. And I mean, all I have is, like the history of the social work profession, and it was slow. But I really do think this kind of coalescing that the White House call for a national certification, of course, it backed down, like with SAMHSA just releasing the national model standards. So these incremental steps where we all start to kind of coalesce around some sameness, really, I think, has to be the fundamental basis for that advancement. I don't think we can go from 0 to 100 right away. I think, we all have different naming conventions, right? And every state has a different kind of set of frame on this. But I do think peer specialists, this is happening on hyperdrive. It's not happening with the social work field. It went so slow. I mean, I think it's 25 years, y'all. We got named in a new standard. Even though we're under CHWs, we got mentioned, as a very young profession. They're national model standards now. States need to be checking against, self-assessing against those national model standards. Do we meet them? Do we meet them 100%? Do we meet them 80%? What is the gap? What do we need to do with that? And then we will start to kind of feel some alignment together, and then really kind of figuring out, and there's national associations who I think, have some real incentive to also try to take on some of this. And that's going to be probably some business modeling too, but I just want to stay away from.
Well, no, I mean, and that's just it. We need to all get together, because if not, we're going to end up with 3 guilds all trying to do something that's basically the same. So that's why I was wondering if there was not some words of wisdom you might have, because I know NAPS is working on it. This isn't to work against any particular group. It's just we need to be pulling in the same direction.
Sure. And I'm an ally, and I'm not a peer specialist too. So, I mean, I'm hoping, I don't see the inner workings, but I am championing advancement. But I think folks who are CPSs, certified peer specialists, peer support workers, that's a place where, I'll talk about policy and finance all day long, but I do want to leave that carefully to the folks who have that lived expertise. And so I'm keeping a little bit of a distance from that one. Although recognizing, my guild, social workers, the history of that, and just wanting that to be on hyperdrive for peer specialists, though. Good question. Okay, y'all. I'm just noticing the time, and I just want to honor everybody's time and attention. Didn't want anybody to have to hang on for the dialogue and conversation, although I'd love talking with y'all all day. Julie, Shannon, the whole team, I want to say thank you for the work, because it gives folks in seats like all of ours just really great information to react and respond from. So just thank you so much for including me in the dialogue.
Oh yeah, both Julie and Wendy are super brilliant, and we at the PRC, we really love working with them. So absolute pleasure, and all things right back double. All right, folks, have a good rest of your day.
Bye, everyone.
Bye-bye.